Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Alison Huffstetler from the Robert Graham Center about primary care MVPs, excellence in cost and outcomes. Let's get started.
Hey, Dr. Dan.
Hey, Faisel. How are you?
I'm doing well. It's good to see you. And Dr. Huffstetler, welcome.
Hi, Faisel. Long time no see. I did see Dan about a week ago, but I'm happy to see you. It's been a while.
When he told me he met with you, and then we looked over the report that you just put out at the end of last year, and I thought, oh my God, what a great time to be able to bring her back on to talk about this.
Well, policy is my game, so anything that is out there floating around with my name on it, always happy to. In fact, more than happy to talk about it. It brings me great joy.
I love it. Obviously, we're very passionate about primary care, and so when we see something coming out about just showing what happens with when you deliver high quality primary care, it's just refreshing for us to be able to share this out there. So let's get started. I mean, we know, but why do you think primary care focused ACOs are so much more effective at saving money and also delivering better care?
It's super easy. It's doing the things they already do that are high value for their organization. And then you bring in the ACO model, which allows for some savings from that high quality care. I mean, it's pretty darn simple. I like to back up because the idea of ACOs is really hard, I think, for some people to understand. It's not intuitive. So when I'm talking about ACOs for this specific report that we did in collaboration with the Primary Care Collaborative, I'm talking about Medicare Shared Savings Plan, ACOs. So they're in the traditional fee-for-service world, and then we are evaluating, they are also part of an ACO, whether that's a large organization, whether it's 10 clinics in their ACO, and they have a third party like Alidate or Innovaccer help them manage their ACO, but it's all the fee-for-service environment. There are lots of novel other ACOs that primary care is working in, but that's what we evaluated for this specific report.
We saw that with the low revenue ACOs that have like 75% or more of the primary care physicians, that they were able to save over twice as much as the other higher revenue counterparts. What do you think? What was the magic behind that?
I would have to draw on some of our qualitative analysis to really answer this question, because our quant data gives us a lot of numbers, but our qualitative gives us that insight into the practices that actually makes a difference. And so we were talking with two folks out of Kansas, and they talked about the fact that they could use all of their registries through the American Board of Family Medicine Prime Registry, and that helped them manage population health. Great, simple thing, free to physicians and family medicine, just like low-hanging fruit there for that highly family medicine-centric ACO. And then we were talking to a group out of Louisiana, and I just love this. I think it's so primary care beautiful. So in anticipation of the holidays, they know that people run out of their meds, that they end up using urgent care more, that they have all of these last minute issues when the clinic's not open. And so they just sent a postcard out to all their patients. And they said, hey, we're going to be closed this day to this day. Make sure that you have your medicines refilled. If you need us, call us before then, just to be aware. And that in itself, I think really does actually make a big difference, because it is the person who runs out of medicine, their blood pressure goes up, they're scared, so they go to the ED, and then the costs go up significantly. So I think it really is that anticipatory world in which family medicine lives. We know our patients, we know our communities, and we're able to then give some forethought into what's going to pop up in the future.
And there's an incentive, right? I mean, in the pure fee-for-service world, if you're owned by a hospital system, there's not necessarily a financial incentive to do that. But if you're taking risk or sharing savings, then thinking about the patient with heart failure and maybe just suggesting that they weigh themselves every day, and if they gain over 5 pounds, maybe they take an extra furosemide until through the weekend, and then if the weight doesn't come down, to come in the office on Monday.
Exactly. And there is value in that small act, and they trust you because, Dan, you've known them for 30 years, and so they know who you are. I think it's that, but it's also the monetary gain. When we look at other studies about why people choose primary care, they never say it's money, right? They always say that they do it because they like relationships and longevity. Yeah, I think it's malarkey. I think people do want to go for money because you still have the top specialties earning the most, right? So I think that the most coveted positions are the ones that oftentimes make more, but we're too altruistic to say it. So if you get into this world where you're finally given the opportunity to make $500,000, $600,000 a year versus $200,000, $240,000 for average family docs, you're right, Dan, that's going to incentivize people to take a little bit more time and ask about that one thing that could prevent them from getting high quality care.
Yeah, and I agree with you. I think primary care physicians tend to not be focused all on money, but none of us got to be physicians by shooting for C's, right? We were all gaming for A's, and if we are now putting ourselves in a system where we're being rewarded or ranked based on our ability to prevent decompensation, it's what we like to do, right? We want to do the right thing for our patients, and we like to be recognized for doing the right thing for our patients.
And everybody in this, most people in our profession like a little healthy competition. You're right. So a little bit of peer-to-peer comparison does not do harm. And a lot of ACOs do provide their metrics back to the clinicians, whether it be specific for the whole practice or just for the individual. They say, here's how you're doing on these things. And if you're number 25 of 28, you're going to be making some changes because you don't want to be 25 anymore.
I love how this information that's coming out is reinforcing what we've been saying, like the multiple touches, the value of earning trust, especially with underserved populations. And like this report just adds to the evidence that's been there, right? That, you create this environment that allows primary care to do what primary care is best at doing, then you'll have better health outcomes. But what do you think over there, with where you're sitting, like what would it take for the political will to really make that shift and put primary care back at the center, like on the national level?
And I think I won't have the full answer for you, because if I did, I'd be going out spreading the word. But I do think that primary care is bipartisan, because most, if not all, legislators have their primary care doc, right? They have someone that they go back to that they trust. And so we are, in large, we are a bipartisan issue. Primary care is looked upon pretty positively overall. There were a couple different commissions in the past that specifically worked at primary care advancement, and over time they have come and gone. And I think it takes having someone to really be the champion of that within the political realm to drive primary care as an issue for many years. It can't be a temporary 2 to 5 year organizational change or commission. It has to be something that sticks around for a longer time. There is motion in the political world. You have people like Senator Whitehouse who are really interested in ACOs, who think that this is an avenue to promote less spending in the healthcare world and get high quality out of it, which he's correct. It is indeed, that's the case. But we have to focus back on the communities that are served to make sure that that actually comes to fruition. And as a prior CHC person, Faisel, I think this hopefully sings true to you in that when we are thinking about how to implement ACOs and other value-based care, we have to make sure it's not cherry picking. It really has to serve all the different communities. And ACOs do that, which is really, really fantastic. One of the metrics we looked at in this report is what are the social deprivation indices, or the level of need in communities that are served by ACOs. And it's a nice bell curve, just like the actual SDI is a nice bell curve. So we know that these are out there doing the right thing for the right communities. And if we take that back to leadership, then maybe they'll see some sparkle in that opportunity, because it does provide billions of dollars of savings overall. What do you think? What is the political motivation that you all have seen?
I've seen it at least at the challenges with scaling out these models, right? The value-based care model, the ones that are local, where they have all because especially I've stayed in the underserved, from Medicare Advantage underserved neighborhood, now back in Medicaid population, and a lot of the work is based on the relationships that we have with the community, the not-for-profit, community providers who help with meeting the unmet social needs. Scaling that is where I've seen that's been the challenge. I see these value-based care models doing very well at the local level, but then scaling it, they run into, because of what you said, people want to see a risk. Okay, where are we from this quarter to this quarter, and where are we from 1 year to the next year? And we know that behavior change and earning trust and all of that, it takes time. especially in populations that have fell through the cracks. So I feel like the opportunity is still there at the local level, but I still don't. I don't. It's a big hurdle to scale.
What I hear you also saying is keeping overhead low is really valuable in that setting. And I think for those ACOs that are primary care led, that are the low revenue ACOs, they have successfully done this. We've heard from many, many groups when we were doing interviews and said, oh, it's just me and Karen and we run all of our metrics and we report and it's 2 people that run the ACO, right? But it's impacting a group of 200,000 or 400,000. Now, if you multiply that, you're going to get the Karen and someone else for that same population. That's where it gets really tricky.
Yeah, and it gets difficult when models start being successful, people start running towards that, and then it seems like maybe it's not as successful anymore, and then the government has to look at cutting more waste. And so that makes it very difficult when the models change. I mean, looking at your report, there are about 4 or 5 different models, starting with the pioneer ACOs. There have been about 4 or 5 different models, and that started in the 2012 time frame.
2012, 13. Mm-hmm.
Yeah, and so it does make it quite hard to change models that quickly. And so you staff up for one model, and then you think it's working, and then they sunset that, and the revenue changes, and that is pretty difficult to do.
How do you continue to keep the lights on when you're going from one day to the next, having uncertainty about that income stream? Absolutely. I think our friends at CMMI are wonderful. They're doing a great job, but most CMMI pilots are too short to demonstrate that longitudinal change. And so people are rightfully hesitant to go into those models when they don't know what the downstream is going to be. They're going to have to transition back to fee for service and change all those metrics again. How do you do that? It's really a challenge.
Right, especially if you're in the rural areas and now you've hired people, and I mean, you've hired friends and neighbors, and now you don't have the revenue to support the friends and neighbors, and that gets to be pretty difficult. So I looked at this report, but I looked at the report you did last year about workforce, and it seems like there's a little bit of a discrepancy, right? Primary care is good, but yet we're losing primary care workforce. And how I would think that would be the first thing we would ask the powers that be. How do we support getting more people into primary care to generate the outcomes that you've so vividly shown that can be done by primary care?
Can we go back to the money conversation? It's so silly, but I truly do think that if there was a little bit more gravitas for primary care, then medical students would choose it. And we talk a lot about, so first off, I love the 2023 report. It's probably my favorite. It's supply and demand. I tried to be a business person. Oh my gosh, it was fun to write and to look at the findings of that report. But it did, like you say, Dan, it just shows that fewer and fewer people are entering primary care, but a lot of people are retiring from primary care or practicing in different avenues like DPC, wonderful, but doesn't have the same access sometimes, or they're going into urgent care settings. So we lose people to other more friendly for lifestyle environments.
I wrote it down here. So I know 2022 was on the heels of COVID, but the number that you wrote, or you and your co-authors wrote in that 2023 report, was that 35,345 primary care physicians retired in 2022, and only 17,238 matched into training programs for primary care. So it's not a few more leaving than coming into it. It's by a factor of 2. And then you and I were both at the Wintergreen meeting, and after the panel you were on, I stayed to listen to the residents talking to some of the students, and they were talking about how call was, and that they were not doing 24-hour call anymore. They were only working 12-hour shifts, which is great. I'm not saying people should be sleep deprived. I'm just saying the people coming out of training now aren't as used to working the long hours as people who are retiring have been used to working. And that's going to impact the number of people having access as well.
I'm curious. So I heard a snippet of that with the residents too, and with interviewees talking about the call schedules from different programs. And I thought to myself, I don't remember anything about call being a major reflection of my time in residency. Residency is hard no matter what your call schedule is. But you're right. It does drive the ability to navigate on 2 hours of sleep and to keep your patients first often, as opposed to going home. There has to be a middle ground. We can't do what we did in the past.
Yeah, I think it'll be interesting to see the rise of the community-based residency programs, because still right now, the bulk of the primary care residency programs are still hospital-based. But I remember when we were giving lectures on value-based care, and we'd meet with the community-based family medicine residency programs. Like they had a focus. It was almost like there was an incentive with maintaining continuity of care, the longitudinal relationship, the earning the trust, whereas the residency programs that were hospital based, it was kind of like, okay, now like they're really doing a hospital residency training, but like, okay, now I got to go to the clinic and put in my time in at the clinic, whereas in the community based ones, I mean, they're prepping them to be successful at like the core of earning trust and all.
Maybe I said this with you all last time, and I apologize if I did, but I think looking at the historical reason that this changed is really key. And going back to literally 1901, when Flexner traveled around, we all reference, beyond Flexner, whatever, but what he actually did was travel around the country for 10 years, and he visited every medical school at the time. And he said, consolidate to universities, right? He said, close all these community programs, get rid of the ones in historically disadvantaged and historically communities of color, get rid of those programs, put it at a university, and that's where everyone should train for their medical training. And he got a lot wrong. He also said you should be able to go practice immediately out of medical school. But something else that I think he got wrong was this consolidation. And so there went from, and I can't remember the numbers anymore, but hundreds of medical schools to about 50 medical schools, one per state. And the long-term effects of that have trickled down such that we don't have community programs in a big spectrum anymore, because this one person decided that they were not providing standardized training. And as opposed to looking into curricular things, he said, just close them. He also got 10 pages in Science magazine at the time to publish this, which if someone gave me 10 pages, slam dunk, you got a lot to write in 10 pages of research.
I mean, the education was different and the pendulum swings. I mean, there was early medical education was in the U.S., people would become doctors if they couldn't do anything else, right? It wasn't considered to be a career to aspire towards. And really, when you think about it, there's the didactic education that we all need. Then there's the experiential, that we need to practice, but we also need the mentoring. And that can be the difference in somebody who's practiced in the community and somebody who's practiced in the academic center, because you have to do things differently if you're needing to see 25 patients a day than if you see 10 patients a day, 2 days a week. It's a different way to go about doing that. But that being said, we need more primary care training programs. We can't afford to close any. We can't afford to close the ones at large teaching hospitals. We can't afford to close community programs. We can't afford to close unopposed programs. We need more of pretty much 50% more retiring than are going into the specialty every year. We need to figure out a way to increase training. And I know some of the newer residency slots have been going to primary care, a significant number. So we just need to encourage more of that to happen.
And to measure primary care is a complex thing, as you all know. So when we see, I think the year that you're commenting on, Dan, there was a 14% attrition rate for primary care physicians. And then if we compare it to that with nurse practitioners and PAs that are filling, it's still like a 4% attrition. We still don't have enough to make up for it. When we pause and look back at how we are emphasizing those training programs and broadening them with GME expansion, we know teaching health centers have great outcomes, right? They're more likely to produce community-based physicians, and they're more likely to stay within 5 miles of where they trained. Awesome. They're staying in rural communities. But the GME expansion pilot, when Congress allotted 1,000 spots, they said, 10% rural, 10% to HIPSAs, 10% training over cap, 10% to states with new medical schools. And then everything was kind of up for grabs for the rest of them. And so people would apply for these primary care positions, but family medicine has a really high retention in primary care. Pediatrics has 50-ish% retention in primary care, whereas internal medicine, you're getting maybe 30% retention in primary care. And so that's a big discrepancy that I don't think is recognized when rulemaking happens, because they simply don't have the expertise. There needs to be a nice collaboration between people sitting in a podcast like this and the people who are writing the rules, because they don't have that experience.
Right. But the other thing, Faisel and I got to go around and visit with a lot of residency programs through the years. So there are some very primary care oriented internal medicine programs. And they turn out a lot of primary care physicians. There are a lot of specialty oriented internal medicine residency programs, and that is something that we don't want to. I think what you're saying is we need to evaluate who's producing the primary care physicians and help them produce more. Yes. And if their internist, great. If their family doctor is great. If their pediatrician's great. But how do we keep them seeing the people in the communities that need to be seen?
Dan, thank you for setting me up with that beautiful entryway. So here's my next paper that we're writing. It's called the GME Impact Quotient. And what it's evaluating is trainees 3 years out of their residency to see if they're still in primary care and where they are. So we can look and give each program a rating. It's just a scaled 0 to 100 rating on what their impact quotient is for an organization or for an outcome, and say, oh, at this program, you retained 90% of your residents in primary care and they were in rural communities. Fabulous. So we have all these different metrics we can look at 3 years out using their a little bit of ABFM data, a little bit of National Plan and Provider Enumeration System data to get real wonky, and we can see where they are, which is awesome. So we can look at that now.
Because that's the other thing, is that when we hear all the discussions around, okay, this is going to save money and this is going to improve health outcomes, but what's the impact on the satisfaction of the physicians? What's the impact with the satisfaction for patients? Or, what are we doing so far as health equity is concerned? But I think right now it's a lot of the conversations go around the cost and the health outcomes.
And while I don't want anybody to be burdened with student debt, I hope people will take the work you're doing and then figure out a way, rather than just making all medical school tuition free, work on making it tuition free for the people who actually are, forgive the medical debt for the people who are actually in the primary care practices, providing those in a, carrying a panel and doing the work that needs to be done in those communities.
When you were visiting residencies, did this come up in conversations about, I have to go into a specific area because I know I'll make more money and I have to pay off my student debt?
The main conversation, I remember just within the last 2 years, hearing the $400,000 student loan debt number being thrown around. That was a big shock. And student loans was a big driver for most of the residents with what direction they wanted to go in life.
And if we get rid of programs like public student loan forgiveness or National Health Service Corps, we'll lose even more people to doing primary care.
That was the other point that came up, is that, a lot of the innovative models at the time, they didn't qualify for student loan. There were these, private companies. A lot of the opportunities for student loan forgiveness were still working in the fee-for-service environment. Like, they're still doing, community health work, but it still very much felt like it was like a product, like a daily productivity and all of that, much more than the, what could we do to help keep somebody out of the emergency room. And so that was a big talking point that came up over and over, student loan debts. And yeah, I'd love to work in a value-based care model, one of these full risk models, but boy, I have this heavy student loan debt, and the options that are available just don't seem appealing. They didn't want to go into that production sort of.
And we know that imprinting happens in residency, but I wonder if imprinting also happens in that first 3 years, 4 years outside of your residency. I bet it does, because that's how you're learning to really get through the day, if you will.
It's interesting. Steve Meixel, who was sort of a master educator at UVA, and I remember asking him when I was a resident, when am I going to feel comfortable? This was back before the internet. When was I going to feel comfortable not having to pull a textbook out with every patient? And he said about 5 years. He said 5 years is where you're going to have seen enough patients that you're going to feel pretty comfortable knowing at least the first step to do for most everything that walks in the door. And I think that is probably true. So I think that imprinting really does occur in that first 5 years out of residency. And that really helps determine what kind of a physician we're all going to be. I don't know. You're much closer to residency than I am. What do you think?
I still have to pull up my reference in most patient scenarios. I will be quite candid. That's something I go to because I simply can't remember all of the information that you need for every odd thing. But I think that's actually really true. And maybe it's 5 years, maybe it's a little, a couple years back or forth. But at that point, you also have then had a family. Oftentimes, you have roots in an area. So then what's the likelihood that you're going to move to a different location to enter into a different care setting? It probably drops off because your life has also changed in those 5 years, in addition to the way that you care for patients.
This is true, although I will say, having Faisel and I have gotten to work with a lot of doctors coming straight out of residency. And the one thing I have noticed is people tend to change jobs more frequently now than maybe they used to. So, but I think a lot of times it's two career families. And so somebody's finishing training and you're looking at how you do that. So, and there's nothing wrong with that. I mean, people should do what they need to do for their families. It is interesting to do that.
Oh yeah. What is it? 70% of graduates don't stay in their first job for more than 3 years. So yes, I agree with you. But are you going to make a big change to entering into a type of work you've never worked in before, like an ACO or like some sort of MA? You might not be comfortable doing that after you've established yourself.
Right. I would tend to agree with you there.
Well, probably more of the hospital leaders, these big system leaders. What would be the advice that you could give them? That you would give them, like, hey, like they're interested in starting to incorporate more of these primary care driven models into their groups, because to attract the best talent.
I think having the direct link between things like ACOs and the clinics that are generating savings would be ideal. And I will be very transparent with you and say, I am in an ACO organization and I had no idea until I saw the name on my database that I was in an ACO organization, because I've never seen the fruits of that labor going into practice at a very large health system. So I think that direct connection would be ideal. And yes, the institution, the health system needs to have some teeth in the game and some financial advancement from that alternative payment model, whatever it is. But having the fruits go directly back to the practices, I think could be a wise way to grow their primary care service lines and improve the retention in their primary care service lines.
Yeah, it makes it difficult when you're running a hospital system, because when you think about it, when you're running a hospital system, the best you ever get is half of what you would have gotten otherwise in a shared savings. If you're in a primary care group and you can keep people out of the hospital, then it's no loss to you and you get half of the money. But if you own the hospital and you keep a patient out of the hospital, you lose half the revenue you would have gotten. And even though you're getting a shared savings, it's half of what you would have gotten otherwise. So I'm not saying it's good, bad, or indifferent. That's the way the payment structures work. And so one person's waste is another person's profit, and are one group. So, and it's interesting. We've had the opportunity to talk to Elliot Fisher in the past, and he's considered to be sort of the father of the ACOs.
He's the Mecca. He's the person you want to know about ACOs. Okay, cool.
Right. But I mean, if you talk to him, his initial idea was not to have hospitals involved with ACOs. He really thought it should be physician groups doing that, because he thought there was going to be a conflict of interest with hospitals and ACOs.
Inherently, there is, absolutely, because there's going to be, they are the higher revenue. They're not going to lead to the savings that a primary care-led ACO is. And I think maybe this is the wild idea that primary care payment is totally separate from that of hospital systems, that we divest in this, the complexities that are reimbursement as they are today, and we pull primary care into its own world and it gets its own model for reimbursement. That would be super hard, because I can't even tell you who is practicing primary care across the United States right now. So it would take some legwork, but maybe that's another in the future. Let's look to see who's doing this to bring people in.
One idea I've got to comment on before we finish up. And one of your ideas in this year's paper was for the patients getting their care from these high quality ACOs, get rid of their Medicare Part B cost sharing, because I know that CMS has come out with some really neat codes for advanced primary care, chronic care management, but you still are asking patients to pay a copay for those. And really having to pay for primary care is like putting the coin slot on the dashboard of the car and making people pay to put their seatbelts on. From a societal standpoint, it makes no sense at all. I mean, we should give the primary care to them for free. So if they will engage in primary care, they will ultimately cost the system less and cost all of us less.
Absolutely. I like the seatbelt analogy. That's very true.
Dr. Dan's good at that. With all the changes, if you had to pick one thing that you'd be most hopeful for in terms of just positive changes for primary care in the near future, what would that be?
Okay, this is coming back to you all because I would love to hear your answers too. In the last 2 weeks, there has been major changes to the way that we provide care to the people with whom we can provide care, all that sort of things. And I have been amazed by the resiliency of a lot of clinicians and the banding together of interdisciplinary individuals to get people the care they need in different settings. And so whether it's a text message chain or an email chain to make sure that we have a plan moving forward, I'm really impressed with how primary care, psychology, mental health providers, social workers have come and said like, oh, we got to change the system because if we don't change it, we're going to lose the trust of patients. So I think that trust is high in primary care, and you see a lot of clinicians leaning in on that right now. So I'd say that's my hope, is that we continue to be those trustworthy places that people can go.
I've seen it the same as well too, just across the country. That's the way that we're all having on the fly. It's like a day to day. Okay, this is what we're going to do. It is what it is. We're going to figure this way moving forward. I mean, for me, if I had to pick, at least from a lot of the rhetoric that's going around, if there's going to be a proper analysis about the diet, especially the underserved areas and underserved communities, about the quality of the food that they're eating, I'm excited to see some change there. But other than that, I mean, I am very worried. I hope that, maybe if the talk and the rhetoric is around making America great, that they can look at where we are so far as life expectancy and all those things, where we are as so far as our healthcare delivery model compared to the other developed countries' healthcare delivery models. Maybe we can have some change there. I don't know, Dr. Dan.
Yeah, I think I hope that all of the physicians and care team members working can continue to focus on the good work that we do and not get so down at all the rhetoric taking place. And then I would hope people understand that whatever we're talking about, we don't make any decisions lightly, and we would really like for the patient and the physician to be able to make their decisions in the exam room and with as little interference as possible with politicians that don't necessarily have medical training to know what's happening there. And I mean, I don't think, I don't want to go into details. I'm going to get myself wrapped around an axle.
It's so hard, right?
Enough, right?
Yeah, it's so hard. You want to be delicate, but I think it comes down to, I know the person in front of me, they trust me, let us make medically sound decisions.
Right.
Because we did this training. You all and I, we spent years and a lot of money to get to that place. So let's do the things we learned how to do.
Well, Dr. Huffstetler, thank you so much for coming back on again. This was a great conversation. What are your thoughts on primary care MVPs, excellence in cost and outcomes? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.